So hello and welcome to today's Scottish Drugs Forum webinar. I'm Kirsten Horsburgh and I'll be chairing today's session on your experiences of providing emergency help to someone having an overdose. We've got some great speakers lined up and we'll have presentations today followed by a Q&A panel as we usually would do. I would really encourage you to put in your questions throughout the presentations. These will be anonymous when they're asked, so we'll get them to the panel at the end of the session. Please do feel free to ask many questions and we'll get through as many as possible at the end. So I'll introduce our first speaker, but also want to say a huge thanks to those who generously contributed to this survey to share their experiences, many of which we appreciate were really traumatic. So a huge thanks to those that did contribute their time to getting this report together with all your survey responses. So I'm going to firstly introduce Martin Anderson, who is the Research Officer for Scottish Drugs Forum, working with me in the Drug Death Prevention team. His work with SDF mainly involves the evaluation of naloxone related projects and campaigns. So Martin, welcome.
So hello everyone, it's nice to meet you and thanks for joining the webinar. First of all, I'm going to present an overview of the report that's been published today about the experiences of providing emergency help to someone having an overdose. So there's quite a lot to cover, so I'll just give a quick overview and also I can answer questions about anything that I don't go into in depth. So a bit of background, I'm sure everyone's going to be familiar with the background anyway, but just in case anyone isn't, obviously we know that Scotland's got the highest drug-related deaths rate in Europe, higher than the rest of UK and Europe. And 2020 there was 1,339 drug-related deaths, which is 25.2 per 100,000 of the population. Very much concentrated into areas of deprivation, a very close association with deaths occurring in people from the most deprived areas. And the most common drugs in drug deaths are opiates, benzos, gabapentin and cocaine. The majority of these deaths are accidental and therefore preventable. That's an important point to make. I'll tell you a little bit about the National Naloxone Programme as well. So Scotland really is a world leader in naloxone provision. In 2011, Scotland was the first country to implement a national naloxone programme, making naloxone kits available after very brief training. Kits can be distributed through the third sector, the NHS, peer distribution networks and so on. There's been 94,000 kits supplied since the start of the programme and 22,000 just in the last recorded year. So a substantial amount of naloxone kits are going out. And these are also take-home naloxone, so you don't have to be a medical professional to administer these. They're for layperson administration. I'll give you a little bit of background as well to this study. So I'm sure you'll all have seen the Stop the Deaths campaign. It was a nationwide awareness raising campaign. Lots of posters, billboards, TV and radio adverts and so on. As part of that campaign, the main goal was to encourage more people to become trained in naloxone and to carry naloxone. And we thought if we're trying to encourage people to do this, we need to understand more about what's actually involved in providing emergency help to people experiencing overdose. We want to know more about the experiences, the people who are being supported and the relationship to the person given the support, the circumstances, interactions with emergency services, and the follow-up support needs of people who have provided emergency support. So this is a purposive sample of people who have provided emergency help to someone experiencing overdose. So we're sampling not randomly or not representatively, but we're trying to sample for people who have had this experience and learn more about their experiences. We put out the survey through the Scottish National Naloxone Network and the SDF website, stopthedeaths.com website, and through SDF social media pages. And the idea is that in these networks there will be a lot of people related to the addictions field and things who are more likely to have provided emergency support at some point. Their research questions were initially developed by Scottish Drugs Forum and they were circulated through SCON and other partners for refinement. And it was an online survey, so there's a lot of questions just asking people to tick boxes and so on. But we also provided quite a lot of free text boxes and a lot of very traumatic experiences were shared in the free text particularly. So I think we got about 385 respondents originally, but out of them 285 had actually provided emergency help to somebody experiencing an overdose. 76% of the people, of the 285, had received naloxone training, so about a quarter were not naloxone trained. 60% of respondents were support workers or healthcare professionals. This is understandable, taking into account the lists SDF distributed it through. But there was a fair amount also of people who were family and friends of the person, emergency service workers, members of the public, people who use drugs, and peer workers and volunteers as well. Most of the respondents came from Greater Glasgow and Clyde, Lanarkshire or Lothian, and there was a bit of a minority spread throughout all other NHS regions. So that's just a basic overview of who actually took part in this survey. So over 3/4 of the survey knew where they could get take-home naloxone, but there's still a fair few there who didn't. And the most commonly identified sources of take-home naloxone kits were through NHS drug services, homeless services, pharmacies, non-NHS drug services, the SVAD click and deliver service, and the peer naloxone service, and a very small number coming from GPs. So what we're thinking about this is obviously you can see most of them are going out through NHS services and homeless services, but peer naloxone services and the SVAD click and deliver may be extending the reach of that. I mean, obviously they're making a substantial contribution to the overall amount, but also maybe extending the reach to groups that other sources wouldn't reach. Over half of the sample had ever administered naloxone to somebody, which is obviously quite a substantial amount, much more than in the wider population, I'm sure. And most of the naloxone being used was the injectable prenoxide. A very small amount of the Nixoid was used as well. So I'll go through this quite fast so I can get to some of the findings. So this is about what happened at the situation of the overdose. Most of the people who were actually helped were a service client or just a stranger, somebody that the person didn't know. So that accounts for about 3/4 of the sample. The people who were actually helped, who'd experienced the overdose. Smaller numbers were help provided to family members, friends, partners or spouses, and a very small number to people who they were using drugs with. And it was interesting that most of these occurred in outdoor environments, also quite a lot in hostels, in the person's home, and quite a fair few within treatment services as well. Since most of these occurred in outdoor environments, it does show the importance of naloxone carriage, because obviously a fair amount of overdose situations are happening in outdoor sort of public settings. We asked all participants what actions they took, and they had to rate all, whether they took all of these actions. So you can see the most common actions were to check their breathing, check for a response, and call 999, and to stay with the person until the ambulance arrived. There is a bit of drop off from 81% who stayed until the ambulance arrived to 64%, well, 65% really, who put them in the recovery position. So fewer people put them in the recovery position. About half them, 51.8%, administered their own naloxone. And going down the list, there's fewer people have provided CPR and so on. But obviously, in not every overdose situation, CPR might not have been required, and administering naloxone might not have been required either. So not all of these things had to be done in each instant. So we got people to rate their interactions with emergency services. And by emergency services, we mean ambulance call handlers, ambulance crews, and police. So we just got them to rate them on a scale of helpful to unhelpful, basically. Most of the 999 call handler interactions were helpful, 68%, but 16% of those were rated as unhelpful. 72% of ambulance crews interactions were helpful, and 11% were unhelpful. We also asked, did ambulance crews attend? And ambulance crews did attend at 77% of the overdose situations, and naloxone was discussed or offered by the ambulance crews to 9% of the situations. Around half of the police interactions were helpful, 51%, and nearly a quarter were unhelpful at 23%. Police were there for just over a third of the incidents, and about 4% of the cases, they said they could confirm the police were carrying take-home naloxone. There might be other cases where the police were, but the person didn't know about it. And just one point we should say about all these statistics is people were recalling incidents from back before the Scottish Ambulance Service were providing take-home naloxone, or before the police carriage of naloxone as well. So they might be recalling incidents from well before that. So the key themes in helpful interactions, I'll just go through these as 999 handlers, ambulance and police. I'll try to summarise what people were saying. So people tended to praise the call handlers if they were calm, empathetic, and gave clear and useful instructions. They praised ambulance crews. They found ambulance crews helpful if they were kind, helpful, non-judgmental. And police interactions were deemed as being helpful if they were friendly, didn't interfere in the medical nature of the scene, and were there to ensure safety and not to make arrests. So this is just, I've only had the chance to have a very small amount of the qualitative data that was typed in by people just for the timing of this, but just to show you where that data is coming from. One person said, 14 minutes of CPR was done by a young female paramedic who didn't want to give up. She was amazing. And that's also talking about the ambulance crews. And then somebody said the police did not interfere with proceedings and they were friendly. They made it clear they were there purely to ensure the safety and not to make arrests. So you can see I'm just summarising themes from the free text. There's a lot more detail around that in the actual full report. And the key themes in unhelpful interactions. Sometimes people said they were advised not to give naloxone by call handlers, or they were asked a lot of questions, things like about maybe the patient weight and things like that, that weren't as relevant. And sometimes incidents were given too low priority and people were told to be waiting hours for an ambulance. And obviously it's an overdose situation, so it should be high priority. Unhelpful interactions from ambulance crews were sometimes when people felt stigmatised, or they were questioned about why they were carrying naloxone or whether they should have used naloxone, or criticised maybe for using naloxone. And unhelpful interactions with police tended to anything about the criminal aspect. If police were asking, well, where did the drugs come from? If police were searching people for drugs, anything like that is obviously rated as being unhelpful by the people who took part in this study. And again, just a couple of examples. The first one's about ambulance crews. So it says they seem more concerned about why we had a naloxone kit than about helping the people who had overdosed. And the second example was talking about police, and it said they were only interested in where the drugs came from and treated us all like suspects. So that's just the themes around helpful and unhelpful interactions. So the outcomes, we asked people what happened in the overdose situation as well. Most of the time the person survived, but a not insignificant amount, over 1 in 20, the person actually died. There's also another roughly a tenth or so, 8%, where the person didn't know the outcome. So the death rates might have been slightly higher. It was clear that naloxone saved a lot of people who otherwise would have died, and that training was really vital in helping recognise the signs of overdose. There's a lot of stories about people surviving that incident, but then dying a week later. That was mentioned a few times. There's also people harms from near fatal overdoses, like brain injuries, brain hemorrhages, like really, really serious things that wouldn't go into death statistics, but still really, also a majorly negative outcome from the situation. And also just the fact that the person providing the support themselves, it was a traumatic event for them as well. And a lot of people were really suffering with the trauma, especially when it was family members involved and things like that. So this is just an example again about the importance of information. This person said the man who overdosed was mistaken by us all as being drunk. He'd been seen wandering about with a can. He was sleeping on the pavement. Somebody said, "Oh, listen to him snoring." I remember this is a symptom of overdose from a leaflet I picked up from the local chemist, and I called the ambulance. So you can see if that person didn't know about the leaflet, didn't have that information that snoring is a sign of overdose, they might have just left that person. That could have been another overdose statistic. So I mentioned there it was quite traumatic for the people involved providing the emergency support. So we asked them about was there support available to them. Most of them who looked for support found it in work, either through colleagues or supervision. About a quarter spoke to friends and family. About a quarter didn't actually feel like they needed support or they couldn't access support. And 64% thought the support was adequate already, and 36% thought there was not adequate support. We gave them a range of potential support options and asked them to rate these as whether it'd be helpful or unhelpful. I wouldn't bother breaking down the stats because pretty much every single support option we offered, people were rating as that would be helpful, and very few people actually said any of these options would be unhelpful. So that's things like online peer support, telephone helplines. These are all things that I think people would benefit from based on responses to this survey. So just 1 minute left for the conclusion. So based on what we found, we think we should ensure that as many people as possible are trained in naloxone and overdose response. Want to further increase the availability of take-home naloxone, maybe extend the reach through pharmacies, GPs, and the extension of peer models, just to get it to groups who maybe aren't getting it just now and getting it really into these substance using networks. Non-fatal overdose pathways should be available in all areas, because there was quite a lot of evidence that people were having subsequent overdoses again after being saved the first time. The call handler should be routinely trained in naloxone protocols, just to make sure they're maybe not advising people not to administer naloxone and things like that when the person thinks that they are observing an overdose. And just a general recognition of the trauma involved in providing help, and just developing adequate support options like the online and telephone support that I've mentioned, because not everybody had management support, and some people were saying, well, they tried speaking to their manager, but there was no support there, and so on. So just an extension of support options as well, I think, would just really benefit people who are providing emergency support. So there we go. That's me, exactly 15 minutes. I'm happy to answer any questions.
Brilliant. Thanks very much for that, Martin. I'll just ask you to stop sharing your screen. I notice people are starting to put questions in for you that we'll come back to at the end for the panel. So thank you very much for that really helpful overview of the study.
Thank you.
Thanks, Martin. Okay, so I am just going to move on now to our colleagues in the Scottish Ambulance Service. So with us today we have Julie McCartney, Lauren Sloey and Mary Munro, who are all from the Scottish Ambulance Service Drug Harm Reduction team. They all joined the ambulance service, bringing with them significant experience of working in frontline drug treatment services, research, education and mental health. So welcome, and over to yourselves. Thank you.
Hi there, good afternoon. Hope you can all hear me all right. Firstly, thank you very much to Scottish Drugs Forum for inviting us along to present to you all today. So we're going to run through a short presentation on the recent work of the Scottish Ambulance Services Drug Harm Reduction team. So today we're going to take you through our work on take-home naloxone, education, stigma, and how we're trying to kind of translate data into practice to positively impact population health. Next slide, please. Thank you. So basically, due to the demand from patients experiencing overdose and reflecting on our unique reach into people's homes, we've been really focused on what we can do to positively influence a reduction in drug deaths across Scotland from an emergency response perspective. So we developed a workforce strategy, and we kicked off in kind of March 2021, looking at training 3,500 ambulance clinicians to supply take-home naloxone. And this year, all our community first responders will also be trained to administer too. We have then embedded the necessary governance to allow us to share information regarding patients that we treat for a non-fatal overdose to ensure that they receive follow-up support, and in essence turn our emergency response into a continuous care pathway for that patient. Next slide, please. Thank you. So through our recent successful poster campaign, we fully encourage the public to ask us for naloxone. So we recognise that as an emergency service as well, that we're naturally able to respond when other support services are closed in the evenings, weekends and public holidays. And a typical example of this was, it was 5 o'clock in the morning on Christmas Day in Edinburgh. We had a 29-year-old male using heroin, in need of clean injecting equipment and also asking for take-home naloxone. But there was no support services open and they were all going to be closed in that area until the 29th of December. So he called the ambulance service, we duly attended, we provided him with what he needed in terms of take-home naloxone, some clean injecting equipment, and had a chat about kind of harm reduction. And using our data sharing pathway, we were able to connect him to support. So we'll give you a little bit more on data sharing in just a second. And the next slide, please. Thank you. So in terms of our actual supply of take-home naloxone, so we kind of got going about March 2021, and we have supplied 1,276 take-home naloxone kits, and that's as of the end of March this year. So who have we given them to? It's quite interesting to kind of get a breakdown of the stats there. So 36% of the kits that we gave went to friends and family, 33% of kits went to patients, 30% have gone to service workers, and 1% are unknown or not recorded, most likely due to kind of teething problems with getting our recording system set up. And also in terms of supply, which is quite important. So 63% of the people who we gave a supply of take-home naloxone to, it was indeed their first supply. So again, kind of showing that unique reach that the ambulance service has got to specifically target naloxone supply to those who need it the most and perhaps don't access any other mainstream health services or NHS services that are giving out naloxone. 21% of the supplies were repeat supplies, so to someone who'd had one before. And then when we kind of broke down the analysis of that, 76% of those repeat supplies were given out due to the previous kit having been used to reverse an overdose. 7% were given out as spare supplies and 9% unknown or not recorded. Next slide, please. So we realise that we do play a hugely vital role in connecting patients who've experienced non-fatal overdose to support services in their local area. And we are now really pleased to say that we have a process in place to automatically share daily information with all 14 health boards in Scotland. So the data table that's on your screen at the moment, it shows that we've shared information on 5,757 incidents within the 9 months from July 2021 until March 2022. And as you can see on the screen, this is broken down by health board area. On average, feedback from the services who received this information, 45% of these patients were not active on the caseload of a community drug service, and they were not being offered or involved in any support at the time of our data sharing. So again, this highlights the importance of SAS data to identify people who are not engaging in support, which is obviously putting them at higher risk of drug-related deaths. I'm just going to hand you over now to Mary to go through our part of our presentation on education and stigma. So over to Mary, and the next slide, please.
Thank you, Julie. So although SAS are known as being an emergency response service, much of the calls we attend are a public health response, including substance use. Through our education, we're helping support staff to understand that the response to drug-related deaths is a public health priority and view substance use through that public health lens. We've been involved with bespoke training in each of our regions and nationally with SDF, focusing on further harm reduction education, including wound care and injection equipment provision. Most of our existing staff within SAS are now trained to supply take-home naloxone, and we now have established continuous education within our student technician programmes and starting to embed in our undergraduate BSc paramedicine programmes throughout Scotland. So any new staff within the service will also be able to supply take-home naloxone for continuation of the programme. In all of our regions, we have engaged with partnership working with a number of services, including our Police Scotland colleagues, local third sector organisations, national organisations and lived experience and peer support groups to promote services and deliver co-produced education. In the west of Scotland, Simon Community recently hosted their first 3-week elective placements with University of West of Scotland and Glasgow Caledonian University for paramedicine students, and one in which we hope to continue, expand and replicate with other partners. Next slide, please. A national priority for the drug harm reduction team in SAS has been to involve people with lived and living experience to help us co-produce materials and help reduce stigma within the service. As the report highlights, although participants' experiences of SAS were overall positive, there were unfortunately, however, some people who experienced poor and negative experiences and attitudes. The nature of SAS response means staff will see individuals at points of crisis and overdose, and rarely in recovery. By hearing individual stories and journeys of people with lived and living experience, it has started to help staff to see substance use differently, explore and change perspectives, and really show recovery as possible. It also emphasises that every interaction staff have can be the difference of a positive experience and connection and potentially first step into support, or a negative experience which can create barriers to future support. Ongoing lived experience work is helping us to educate staff in appropriate language and help SAS start to make steps to becoming a trauma-informed service where we can look past what is wrong to what has happened and why someone may be experiencing substance-related problems. We also provide a trauma-informed approach in our discussions on naloxone administration and getting staff to think about the experience of the person during and after a near-fatal overdose and how they can help support in a trauma-informed way. I'll now pass you over to my colleague Lauren, who is the West lead.
Thanks, Mary. Can we pop on to the next slide, please? Thank you. So throughout the programme of work that we have been doing, data analysis has of course formed a fairly significant part of what it is that we actually do. And translating this into practice has been made possible by our senior clinical outcomes analyst, Abby McQueen. So the initial piece of work was around finding the data flags that allowed us to actually see what an overdose looks like in the ambulance service systems. And since that, we have worked together to create some regional trends analysis, which we can present to ADP and health and social care partners to help inform local resource allocation. What we can see on the screen here is just an example of some of the trends analysis, which shows heat maps of the areas most impacted by near fatal overdose, and then some further identification just at the bottom left-hand side of whether or not incidents happen at home or from away from home locations. Beyond that as well, though, we can provide some trends around out of the day of the week, and this is about enhancing understanding of high-risk times for near fatal overdose. So in some regions, informing resource allocation has looked like mobilising harm reduction vehicles into identified areas of high risk that have maybe previously fallen in between gaps of service provision. And in others, it's supported some understanding about the needs around service opening times and also actually the location of those services as well. Next slide, please. So beyond near fatal overdose, there are of course other things that can act as potential data flags. And we want to continue to look for them to ensure that the data that we're providing to partners is able to capture not just the people who have already experienced overdose, but those who are also at risk of future fatal overdose and potentially other drug-related harms as well. We're keen to use some of the multiple complex needs or health harm behaviours or harm reduction provision needs listed in the top section on the slide here within our future analysis. And so to better meet the needs of the sort of wider complex needs of the population, we began collaborating with partners to look at SaaS processing and experiences of individuals when they're engaging with the ambulance service. And that's from engagement with emergency call handlers through to interactions with the ambulance crews, and then actually even into the crew's interaction with their electronic recording systems, just so that we can find the areas that we can improve in all areas of the system. We've also been working alongside some drug death associate researchers to ensure that drug death risk stratification is considered within data flagging as well, just to allow us to better monitor how, when and why individuals engage with emergency care and when the patterns and reasons for engagement might identify future fatal risk of overdose. All of this work kind of going on behind the scenes is because we recognise the capacity of SaaS, who have such a unique reach into the community, to support the earliest possible identification of need and subsequently support access to integrated care pathways. And we can see a lot of future potential in translating data into practice. Some of those things just listed at the bottom of the screen here. Just with recognising how data rich the ambulance service is, we've even been able to do some things around monitoring and surveillance and actually confirming some hypotheses that have previously been brought up about maybe where individuals travel from and to inject in high risk outdoor away from home locations. Next slide, please. Thank you. So upon initiation of the workstream, it was pretty evident that the ambulance service was going to play a role in tertiary and then to an extent secondary measures of harm reduction, just by ensuring that individuals were going to have access to the right harm reduction, the support like take home naloxone, and then also having the option to be connected to support services. But as we've progressed, we've recognised a number of opportunities that are actually across primary, secondary and tertiary prevention, and we're starting to gain an understanding of the potential initiatives that we can look at. We are seeking to better understand the SaaS role in stopping the cycle, and we can see the value in reaching this understanding with the voices of those branded as hard to reach and most impacted by care experience, poverty, deprivation, substance use, and a number of missed opportunities. So we are really pleased to have the support from local officials and community advocates to begin some development around community engagement, where we can invite community members into space to actually learn from one another and think about how this service is going to look like in the future, just ensuring that a very wide audience of people can feel valued, heard and seen by the ambulance service. Next slide, please. And just some contact information for the team. You're welcome to reach out to us, but if we can leave that out for a second so people can take a little note, but other than that I will pass back to Kirsten.
Brilliant. Thank you very much to all three of you. The work that has been going on with this team in Scottish Ambulance Service, I have to say, is absolutely phenomenal and is so progressive in what's been able to be achieved over the course of that work, not just around take-home naloxone distribution, but as you can quite evidently see from the presentation, all the other strands of work that are so important for us when we're working in partnership with the ambulance service. Thanks very much for that presentation, and we'll come back to you all in the discussion at the end, I'm sure. So thank you. Okay, so I'm just going to move on now to our next speaker, who is Chief Inspector for Substance Harm Prevention, Anton Stevenson from Police Scotland. So thank you, Anton, and over to your good self.
Yeah, good afternoon, everyone. Thank you, Kirsten. Apologies, folks. I will need to do this with my camera off, so you don't get the pleasure of my face. My broadband is playing up, and hopefully Kirsten's team will be able to share the presentation for me. I'm just going to talk for the next 5 minutes in relation to our test of change or pilot for the police carriage and use of naloxone. There was a lot of support given to us by a number of partners, many of whom are here today, the Scottish Drugs Forum, SFAD, the Ambulance Service and the Drugs Death Task Force, who funded the pilot, and I'll come back to that in just a moment. Can I have the next slide, please? So the test of change ran for a 6-month period from the 1st of May to 31st of October last year, initially within 3 test bed areas. That was Falkirk, Glasgow East and Dundee City. And at the end of the initial training, where we had some naloxone left over, that was expanded to Stirling Community Policing Team, the custody facilities within the test bed areas that didn't have 24/7 medical provision on site, and also up in Caithness. It was felt that that would give us a good sort of Scotland-wide view, and also the view of a more rural, isolated community. I'll not go into a lecture on the background of naloxone, but as we go through the presentation, you'll see some comments at the bottom of some of the slides which have come from SFAD, and I'll mention why as we go through. But in total, there were 808 officers trained, 665 of which, as 81%, if I've got my maths right, volunteered to take part in the test of change. And again, I'll come back to the voluntary nature of it in just a moment. Now, these figures relate to the test of change only. So during that 6-month period, there were 53 people administered naloxone by police officers. That number is now in excess of 70, and that's with less than 4% of the force trained in carrying naloxone. And what the evaluation team found is that our rate of use of naloxone is almost identical to that of the communities we serve. So we're sort of reflective of the community rate. It says that all casualties received further medical assistance after naloxone and left of their own volition. Sadly, we have had one person who now hasn't survived after being administered naloxone. The officers actually believed the person was already sadly deceased, but nevertheless administered naloxone to try and save a life. And we have had uses in every single test of change area by officers of every rank across the board. Can I have the next slide, please? So just in case anyone hasn't seen them before, I know a lot of people on the call will have. This is what the officers are carrying, which is the Nixoid spray. I know it was mentioned earlier that the majority of naloxone, part of the take-home naloxone programme, is the injectors. A lot of officers didn't feel comfortable using needles, and the spray was something they were far more comfortable in using. That said, we have had officers out with the test bed area use injectable naloxone. That was a person's own naloxone, and they used that and managed to save the gentleman's life. But this is what our officers are carrying. Each officer has a pouch with 2 sets of Nixoid in it. Next slide, please. So there were a number of issues and barriers ahead of our training, and Kirsten and various others on this call helped us to sort of develop the training to address that. And you'll see some more images of what the officers are carrying here. And one of the most important points to get across to our officers is that you don't need to be a trained diagnostician. It's for suspected overdose. You don't need a confirmed diagnosis for it. One of the big concerns is what happens if it doesn't work, if the person dies in the aftercare. And I think it was important that the officers realised that you're trying to save a life. This is emergency first aid to try and prevent a person from dying. If you're not able to save the person, that doesn't make you liable for that person's death. You're doing everything in your power to save them. There were some concerns about the ambulance service, and will the ambulance service leave it to the police because we're carrying this equipment? And I'll come on to that on another slide in just a moment. There were some concerns about the legalities, but we were able to cover that. Obviously, a lot of people on the call will know that it is covered by the human medicine regulations. And so for that, we developed a full policy, guidance and a bespoke training package that covered all of these issues, and the kit, the storage, replacement, should you use it, lose it, break it, or it expires. And one of the big ones is, why was it voluntary? That was a concern for a lot of officers. It's unusual in policing for something like this to be voluntary. And the reasoning behind that was we wanted to tease out any stigmas, any barriers. It's difficult to tease out if there's any stigmas or barriers if we instruct people to do something. And for anyone that's not aware, Police Scotland's not that old an organisation, and there's been significant change in policing over the last few years, and a lot of officers are sort of change weary, and this was an excellent opportunity for our staff to be more engaged in the change process and develop that future policy. So that's very much where that came from. Next slide, please. So over the course of the test of change and continuing to date, we have regular administrations by officers, and it's from a mixture of sources and situations. There are calls from members of the public where they suspect an overdose, or we have had officers discovering a casualty lying in public places. Some of the calls from the public have been down to also calls about a body being dumped, and it was suspected as a dead body, but the officers have arrived, it was a person in overdose, and they managed to save them. We've had a number of people collapse into unconsciousness whilst in police custody for unrelated matters, be it in a police vehicle or in a police building. We have had people collapsing during sieges and during Misuse of Drugs Act searches on a house where they swallowed something prior to the officers coming in, so the officers were unaware. And I think it was 45 minutes into the search of the house, the person's collapsed. Thankfully, the officers had naloxone with them. And very sadly, deliberate overdoses by suicidal missing people, which I think won't come as a surprise to a lot of people on this call, that there are complex needs. It's very rare that drug misuse presents on its own. And I think that last one in particular blows a lot of myths out of the window, and a lot of stereotypes. So there's a lot of very, very vulnerable people here. The naloxone has behaved exactly as expected on all occasions, which I think was very reassuring to officers. And the Scottish Ambulance Service response here, we entered into a minute of agreement with them regarding their response. And the understanding was that officers shouldn't administer this until they know that expert medical care is en route and they've contacted an ambulance. Now, the average time was 9.7 minutes per incident, some of them far, far less than that. So I think it's important to acknowledge the outstanding performance of the ambulance service here in the backdrop of this was at the height of the pandemic, when the ambulance service were under massive pressure. And that was very well documented, as were all aspects of the health system, but the ambulance service were under particular strain at that time and still managed, really impressive responses to our incidents. So I think there's worthy of a special mention there. Next slide, please. The test of change itself was subject of an independent evaluation set up by the Scottish Institute for Policing Research and funded by the Drugs Death Task Force. And you can see here what they were looking at, which was officers' attitude towards drug use in people who have a drug dependency, officers' understanding and awareness of drug overdose incidents and naloxone as a first aid intervention, its effectiveness. They also wanted to look at the experience of officers carrying it and using it. What were the barriers and the facilitators, and that was actual or perceived, and feedback from local communities and people with lived and living experience were absolutely crucial to this evaluation. And the next slide, please. Following publication of the evaluation, I presented those findings and the report to our Strategic Leadership Board. That's the Chief Constable and the Executive. And the Chief Constable approved a national rollout to all officers up to and including the rank of Inspector. The more senior ranks can be trained if they want, but very few of us are out on operational duties on a regular basis. I carry it, and a lot of the senior officers are actually volunteering to be trained in it as well. The training and carriage of the naloxone is mandatory for all officers in Scotland. And the naloxone will be a high profile carriage, which brings me back to a point I mentioned earlier on in terms of the feedback that you're seeing at the bottom of some of the slides here. It was important for us to try and break down barriers and stigmas so that people know that we're actually there to help. We're not just there to arrest people, and preservation of life is absolutely critical and a fundamental role of police officers. And SFAD reported to us, we weren't aware that they were gathering this information, but they were seeing an increase in demand for take-home naloxone as a result of the high-profile carriage of naloxone by police officers. Members of the public were asking, what's that on your belt? What does that do? You see at the bottom, you see, and a solicitor saw officers carrying it when he was in visiting a client in police custody, and that's inspired a lot of other people to go and source naloxone. Next slide, please. So it said at the bottom there, we've got a 4-phase delivery plan in relation to this. The good news is phase 1 is complete, so all of the original test bed areas where officers declined to take part in the test of change, all of those officers who were trained are now equipped with naloxone, so there's in excess of 800 officers carrying it now. Some of the officers who were trained will have transferred. That's the nature of policing, people move around, so it's already starting to spread across the country. Phase 2 is well underway. The naloxone champions will be getting trained this month with support from the Scottish Drugs Forum, which I'm very, very grateful for. And they'll be there to support officers locally in the divisions with any questions. At that point, we'll move on to phase 3, where everyone will complete an online training package, again, developed in partnership with Scottish Drugs Forum. And after that, everyone will have their pouches and naloxone delivered to them. And after that, anybody new joining the police will have it issued to them at the Scottish Police College. Next slide, please. Probably the only other point to touch on there is the refresher training. Officers undertake officer safety training and first aid training every single year. It's a 2-day course every year where they go through refresher training. So there will be refresher naloxone training as part of that. Also, as part of the naloxone training, both initial and refresher will be stigma training, because one of the things that was identified, well, it's not widespread, but still does exist within policing, was that stigma was a barrier to officers volunteering to take part in the test of change. So addressing that stigma is absolutely a priority for the Chief Constable. So both the initial training and the annual refresher training and additional training that will go out through the Scottish Police College will start in the coming months in terms of challenging that stigma so that it's not a barrier in the future. And that takes me on to any questions, which I know we're going to move to the end. So at this point, I'll shut up. I'll not bore folk to death with the funding and procurement side of things. Less to say that the Scottish Government has thankfully agreed to fully fund the naloxone rollout for Police Scotland, so there will be no cost coming out of the sort of core budget of Police Scotland, which will remain for frontline policing. So I'm very grateful to them as well. And I'll hand back to yourself, Kirsten, and I'll take questions at the end.
Brilliant. Thanks very much, Anton. And yeah, great news that the project's been rolled out across the entire police service. So I'm sure we'll come back to some discussion on that at the end. So thank you for that. Okay, I'm going to introduce our last speaker, who is Hannah Robertson-Newman. Hannah's an outreach worker for Simon Community Scotland based in the Street Outreach team in Edinburgh. Thanks, Hannah, and over to you.
Thank you so much. Hello, everyone. My name's Hannah Robertson-Newman. I work with Simon Community Scotland, and I've been asked to speak here as I've got quite a lot of personal experience giving naloxone to some of the people that we support and being involved in overdose situations. And I'm also very, very passionate about overdose prevention and breaking down the stigma and trying to just get the naloxone out to as many people as possible, and passing on the message we have. Lisa, can you share the next slide, please? Okay. So for those who don't know, Simon Community is the largest provider of homelessness services in Scotland. And this is built around various different services. So we've got outreach street teams, drop-in hubs, accommodation services, housing first, and visiting housing support services, as well as various specialist services. It's always expanding. And we run pretty much all over the central belt. So there's Glasgow, Edinburgh, Perth, North Lanarkshire and Dunbartonshire. So it's a pretty big organisation, and even though it is mainly built to support people who experience homelessness, we understand that there's a person in the middle of that. There is a person who has various different complex issues, and within Simon Community Scotland, around 80% of the people we support struggle with issues with substance use as a result of trauma that they've experienced. And this is a key concept for us. So we're always looking at ways to support that person where they're at. Can you share the next slide, Kirsten? Sorry, Lisa. So we've had various different projects within Simon Community of how we can bring naloxone and overdose safety into the support plans for the people that we support. So we have overdose training. Every member of staff or volunteer who comes through Simon Community Scotland has been naloxone trained. We have various trainers in different parts of the company. And we really, our admin staff get trained. Anyone that comes through our doors will get trained with naloxone, because we understand that this can happen at any time. And we also understand that a lot of the people that we support will recognize us in the street, even if we are not their key support worker. So we're very aware of that. We also have a full harm reduction stance as well. We do the best that we can. And we have training so that support workers can give naloxone to the people that we support, and try and encourage them to carry it on the street. We've recently introduced our naloxone safety plan, which is a plan for people who are resident who are at risk of an overdose, where we can put their wishes of how we handle that situation at the forefront. So for an example, we would ask them, where would they like to be injected? Would it be the arm or the leg? Do they have a preference? Do they want someone to go with them in the ambulance, or do they want time on their own? And we really try and put the experience of the person we support at the center of everything we do, because we understand that this is a traumatic experience for the person as well. And we also have a high threshold policy in our support services. So we understand that a lot of people that we do support will likely be under the influence, and we would all rather we were able to keep an eye on them and they were safe than turn away. And because of these different things, in the last 12 months, community staff at Simon Community have provided naloxone 150 times. Can you go on to the next slide, please? Okay, that's a very dodgy photo of me, so you guys can enjoy that. I just wanted to explain my personal experience and why I'm so passionate about naloxone and naloxone provision. So I've been working with the street team in Edinburgh for almost 4 years in July. And during that 4 years, I've been involved in a naloxone situation 18 times. So there's been 18 different times that I've had to give naloxone to a client, or give naloxone to someone we support, or give it to or support someone else that's doing that. This is a variety of different experiences. Some have been in accommodation, some have been on the street, some have been in the support services that we have. And now I'm a naloxone trainer. So last year I trained 109 people in Edinburgh about giving naloxone and responding to an overdose situation. And my ethos for this training is it's open to anyone. So it's not just Simon community staff that I've trained. Anyone that wants to be trained, I will train. I also wanted to read, recently I wrote a small blog piece about the first time that I gave naloxone to a person that I supported. I've cut it down quite a lot, but I just wanted to give an example to kind of emphasize the experience that it is to respond in that situation. So I'm just going to read this out to you. We turned a corner and I noticed a few bodies on the crowd and that the steady stream of people was moving out the way of something. Freddie, my colleague, and I both go over to investigate. This is when I first start to worry. It is a body laying on the ground. The spectators look panicked. Someone was on the phone, but nobody is touching him. Nobody seems to want to get too close. He is young, a man wearing loose clothing that is ripped and stained in places. He's laying out on the dirty floor with a blanket over his legs that is soaked through. He is painfully thin and his face has an expression of lost oblivion. He could easily be mistaken for a pile of rubbish tossed to the side, not waiting for someone else to come along and clean up. There's a cup in front of him with a few coppers in. I get close and I look at his face. My stomach sinks. I know him. Tony. He is young, no older than 22. I sat with him only a few days before talking about his life. He is charismatic and cheeky. Tony only knows the streets. He was raised in a protective community bubble of shared trauma. I push past the onlookers and try to pretend that I am the confident professional I am meant to be. And I say I know him when people look. I get close to his face and call his name. No response. His eyes are open and glazed. I have never noticed before they are a sharp blue. I look closer, my heart beating. I see the unmistakable tiny pinpricks of his pupils that goes hand in hand with opiate use. I shake his shoulder and call his name. I pray to anyone that will listen that he will sit up and tell me to go away, tell me that I'm overreacting and he is fine, anything, nothing. My heart sinks and I look at Freddie, who shares my concerns. This is an overdose. My attention goes back to Tony. He looks younger than 22. He could easily pass for a high school kid. I guess in some way, in his limited experiences in life, this is true. I put my hand under his head. I want to protect him from the cold concrete. Freddie and I work to lay him flat. He is soaked through and bony. I am also soggy now, and I am on the ground with him. I am shaking with a mixture of cold and adrenaline. I listen to his breathing. It is shallow, but it is there. Relief for the first time. This means I don't need to do CPR at this moment. I go to my bag and pull out the yellow box of the naloxone kit and peel the plastic wrapper. I crack the case open in the way I was taught only a few weeks ago, and it springs open, so seamless. Inside, there are 2 blue needles, a syringe with a stopper on the top, and an instruction leaflet. Everything you need to save a life. I pick up one needle encased in a plastic wrapper in a barrel. I've trained in this action, attaching the needle to the barrel, but my hands are shaking and I keep fumbling with the stopper. Freddie takes it off me and does it. I call Tony's name again and I roll him into the recovery position on his side. One hand to protect his head from the cold concrete and one leg bent up. It looks just like how I sleep. Freddie hands me the needle. He has a pleading look on his face. It's his first time seeing this as well, and I can tell he wants me to take the lead. I take the needle in my hand and look at Tony. He is drooling slightly, his breath slow and raspy. I inject him in the leg with naloxone. It's a weird sensation injecting another human, and I thank the designer of the naloxone kit silently in my head for having the forethought of measuring out the different dosages on the side of the syringe. I sit back. I know I need to wait 2 to 3 minutes. I keep calling Tony's name, hoping to bring him back to me. There is long, heavy pause while the rain keeps coming down and a puddle has started to form right where I'm sitting. Tony stirs. He lets out a long moan, and I hear his breathing start to return to normal. To save someone from an overdose means they have time to save themselves. And I thank everything that soggy night that I was there with my naloxone kit when Tony needed me. Great. Lisa, can you change slides, please? A lot of times, 40% of the people surveyed in this study were workers who have been involved in the naloxone situation. And a lot of that is because we are often on the ground with people at the time. And we spend a lot of time in and out of communities and checking in on people. So sometimes we are the first people to notice when that person is starting to dip or something's going wrong. And also I noticed that quite a lot of people that I support and the rest of the team supports, they know and trust us and know that we're not going to be judgmental. So if they have a friend that they're worried about, they will potentially bring that friend to one of us so that we can intervene with naloxone. And I was saying it is a traumatic experience. I've done 18 overdoses, dealt with 18 overdoses so far, and each one of them has had an effect and had an impact. But I was saying my team in Edinburgh, we lost 4 people for overdose that we were supporting in the last 10 days. And looking at how this affects me and the team, I would say that that is a bigger effect than dealing with a naloxone situation, because at least when you are involved in an overdose situation, you're saving a life and you're bringing that person back. When you lose someone that you've been working with or someone you've been supporting, that story's kind of ended. So yeah, I was just wanting to say that.
So thank you so much to all the speakers. Please could everybody rejoin, put your cameras on, and I'm also going to invite a few extra folks onto the screen as well. So I've got my colleague Austin Smith, who's been monitoring the questions in the background. I am also joined by my colleague KerryAnn Colquhoun, who is part of the drug death prevention team at Scottish Drugs Forum and works on pure naloxone, and also Suzanne Gallagher from Scottish Families Affected by Alcohol and Drugs. So first, I just wanted to come first to yourself, Suze, just because I know there was a lot of family members who contributed to the report, to the survey, sorry, and shared their experiences. So just wanted to come to yourself for any words of wisdom from the families' perspective around some of the things that have been shared. Thank you.
As you mentioned there was a number of families who took part in that study, and it's really great to see that their experiences are being acknowledged and that they've been able to contribute to this. Through our national helpline, the fear around the death of somebody's loved one is a common discussion we have with family members on a daily basis. The fear of losing their loved one is a huge anxiety factor for families. And a lot of families have suffered real trauma responding to an overdose, many on more than one occasion. So not having appropriate support to allow them to reflect on that experience, but also to access ongoing support, can be really detrimental to their overall well-being. And when we see people contact us, they're in a really difficult place because that's been, bubbling away in the background for a really long period of time. Martin mentioned earlier about the call for near-fatal overdose pathways, and we would absolutely strongly back that call for there to be near-fatal overdose pathways in every area, and also that they recognise the support that family members are going to need. Because Scottish Families, obviously on a national basis, we're able to meet that need to support families through our national support service, but we're also here to look to provide families with information and referrals to services on a kind of locality basis. You have also mentioned we've got our Click and Deliver naloxone service, which was 2 years old this week. And since the launch of the service, we've issued 6,121 kits across Scotland. So we see that service as an addition to local provision. That's just like a wee cherry on top of the cake to kind of make sure that we can get that reach out as far as possible. But For families that we regularly speak to, many require actual specific counselling to come to terms with the trauma of experiencing that overdose situation, and combined with ongoing family support to look at their coping responses to manage their well-being. And our ideal aim is to prevent the loss of their loved one. So we would really advocate that services and organisation really do prioritise the needs of families, and we're here to support in any way that we can.
Brilliant, thank you, Suze. KerryAnn, over to yourself if you wanted to share some of your experiences.
Thanks, Kirsten, and thanks for asking me to be part of today's panel. It's always good to come and share my experiences now that I've had kind of over the past 25 years. So first of all, now responding to somebody who's overdosed, and my experience can be really traumatic. And the first rule when I'm delivering the training for training is to tell people try not to panic. But when you're in that situation now, it can be a kind of different picture. And before I had ever received any naloxone training, when I was younger, I remember being age 15 and responding to a family member who had overdosed. And the first thing I can remember doing now is freezing and kind of not knowing what to do, and going to like a neighbour and asking kind of them to call an ambulance, because I didn't have any mobile phones back then, and just really feeling powerless now to the person. And we talk, when I'm delivering the training now today, we talk about the myths and what not to do to respond to overdose. And I'm guilty, of doing some of the myths when I was younger, only because I hadn't received the proper training. But since 12 years ago, being trained and training for training with the Scottish Drugs Board, now I'm able to respond in the correct manner. When I worked in frontline services in homeless and addictions now for over the past 10 years. And I was thinking about this the other night, and I've probably responded to quite a few overdoses. And again, it can be quite traumatic, and the kind of nerves kick in. But if I can give anybody now any kind of advice, it's to try and kind of stay calm and try and think take a couple of seconds to think exactly what you're going to be doing. And the most beneficial thing as well for me as a worker is after it now, because when I was younger, I didn't get any sort of debrief or anything like that, and it left me really, really traumatised. And then as a worker now, kind of getting a debrief, not just with yourself, but also the person that you're administering the naloxone to. And I know that can be quite difficult, because a lot of people, they've only worked in frontline services, so they probably don't have any contact with the individual again. And I think always to remember as well that in the Pronoxide box in the kit is a patient leaflet which speaks you through it step by step exactly what to do. And be assured that if you're calling an ambulance because you need to administer it, the call handler, I've always had really, really good call handlers, and they've given me really good advice. And one of the things as well, sorry, I'm not going cussing, one of the other things is to try and put them on loudspeaker for your mobile phone, so that it frees up to your hands. Again, if you're dealing right now, you're administering the naloxone. But I know I've only got a short amount of time cussing, so I'll just leave it there. And thanks a lot for asking me to come on. Cheers.
Brilliant, thanks, KerryAnn. And I think, for all of this, and what probably one of the things for me for the report is, it's just so frequent for people now to be having these experiences, and obviously we want to reduce the number of overdoses that are happening in the first place. Austin, over to yourself. Are you able to give us some snippets of questions?
Yeah, there's a lot of questions, and I see they're still coming in. Some of them are about the beliefs and attitudes of colleagues, and how you challenge some of those beliefs and attitudes. And I suppose in the case of the ambulance service, the question is what's worked to do that, and how do you roll that out, make that national, so it affects the whole staff team. And in terms of Police Scotland, why is there resistance amongst that residue of officers who don't want to volunteer, and it's their ongoing work with that group?
Yeah, I'll maybe come in there. I saw a few of the questions popping in there. In terms of, I think one of the questions was there any data as to why officers chose not to carry naloxone? It was a free choice for officers. If they wanted to take it, they could take it. If they didn't, they could just leave it and leave. But some officers did stay behind at the end to tell us why they didn't want to participate, and also there were one-to-ones, focus groups with the evaluation team, which is completely independent to Police Scotland, and also surveys that were sent out to every officer who was trained so that they could have their say. And the sort of common themes where a number of officers were concerned that it was voluntary and saying we shouldn't decide whether or not this is a role for the police, that's a matter for the Chief Constable. And if I'm volunteering to do it, am I still sort of covered and protected if I do something like that? Some were concerned about, will the Scottish Ambulance Service step back from the responsibilities and leave this to the police? What I can say is that there hasn't been a single occasion where the ambulance service have asked the police to go in place of an ambulance. It's a life-threatening medical emergency, and they're absolutely the right agency to respond to that. And a number of officers said that they were concerned because the Federation didn't support it, and that's why they were declining to take part at that point. And on that point, I see somebody saying, have the Federation changed their position on this? A simple answer to that is no. And in terms of sort of challenging those stigmas and turning it around sort of into a positive, I think when officers are hearing of the fact that their colleagues have been able to save someone's life, that is a big changer in terms of culture. The fact that it will be standard kit that you come out of the police college with when you join, I think that will be an interesting one to look at in years to come in terms of changing attitudes when it's just what you've always been issued with in policing. It's not a change for you in terms of your approach. But we actually had some officers who were arriving unaware of what the law was and said that they didn't feel they had enough time to think about it at that stage. And we did have officers who, after they left the training, came back a couple of weeks later and said, I've been away, I've had to think about it, I now wish to take part. So it's probably important to mention that the 81%, the vast majority of officers did decide to take part in that, and then a number after that did change their mind and chose to carry it in the naloxone. And it will become part of standard kit. And as I said, the stigma training will be part of the initial and the refresher training, and there'll also be stigma training as part of all new recruits training when they come through the Scottish Police College. So I think that will go a long way to sort of changing any attitudes. Thankfully, it's in the minority, but it's still something that has to be changed. I hope that answers folks' questions.
Thanks, Anton. And I noticed that Mary had done a substantial response to a question in the Q&A as well. So I'm assuming that people viewing can see that as well, because it was answered publicly. Lisa, is that right?
Yeah, that's right.
Good stuff. So was there another one, Austin, you want to just, I'm aware of the time, so I wanted to get through a couple.
Yeah, just a kind of technical questions about the different preparations of naloxone. So do we have a sense of the demand and also of the supply? Is that affect the numbers?
Somebody from SAS maybe want to answer that one? Do you mean, Austin? Sorry, Julie, were you going to come in?
No, I was just going to say, I don't know if I can answer that because it's about Nixoid and Prenoxide. We only offer Prenoxide in terms of supply. So I was just wondering if Suze might have some information about kind of public campaign and basically obviously people getting trained online and then actually coming forward requesting a kit and what type of kit they're most requesting at the moment.
So last year, so looking at the year, obviously 2020 to 2021, we really only had Prenoxide, so that was the only option. Looking at last year, obviously 2021 into 2022 financial years, we've got the kind of full year statistics. So we're sitting at about 63% Prenoxide request and 37% Nixoid. So far this year, it's sitting at 52% Nixoid to 48% Prenoxide. So it does kind of move, but you tend to find that people are requesting Nixoid because it's something new. They're maybe aware of Prenoxide and they want to see what Nixoid is, or the main reason that people want it is the fact that there's not a needle involved in it. So it is a bit, people have an option to the kit of choice, but we kind of budget it on a kind of 50-50 split, but it's slightly more towards Nixoid at the moment.
Thanks, folks. And yeah, I think most areas across Scotland now provide both, but there are still some restrictions as to Prenoxide being the first line supply in some areas where it's slightly more challenging to get intranasal. So there are differences across the country, but most areas now have both available. Austin?
There's a lot of questions about whether the slides are available, so I can speak to the people who presented this afternoon, maybe send those out to attendees in a PDF format. And the other question was just about, for Martin's kind of technicalities about research, was about the representativeness of the self-selecting sample of people who responded, and also about the timing of the survey. So the low figure for police carriage, does that just reflect the fact that there wasn't a lot of police carriage going on at the time?
Yeah, I'll come in on those, that's fine. So definitely, I mean, it's not a representative sample, but the strength of the sample is it's a targeted sample on people who are likely to have experienced this situation. And that's how we get insight into a large number of experiences. So no, it's not representative in that sense, but it had to be that way so we could capture these experiences. And the recommendations for future research in the actual report, we do suggest, and we'd probably like to plan out some further research that engages more with some of the groups that weren't as well represented in this sample. This sample is very closely related to SDF networks and things like that. You know, that's who's going to, a lot of people are connected to the addictions field, less people who use drugs, for example. So there's definitely more research to be done, but we think it's a really good start and just getting an insight into some of the issues, especially for like support workers and professionals and stuff. But there was a fair number of like family members. I know it was a minority, but the qualitative stuff, they still had equal chance to leave comments, and some of the qualitative data in there coming from people who use drugs and stuff gives you an insight into that as well. Sorry, Austin, what was the timing? Oh, the timing, yeah. So that's the thing. It's because we were just asking people to think about past experiences, and we don't know how far back they're actually recalling. So I'd imagine a lot of the experiences don't reflect current carriage by police and things like that. It's just people thinking back to previous experiences. That'll be the reason for that.
Thank you, and I'm sorry, but we're out of time because we've managed to get through a few questions, as is always the case. There's a lot of unanswered ones, so if there's anything in particular that people still require answer to, I think we could leave our emails and people can certainly get in touch, and we'll make sure that those questions are answered for you. But I would just like to let you know that this webinar has been recorded and it will be published on the SDF YouTube channel as soon as possible. We'll be sending out an evaluation shortly, and it would be really helpful if you could complete that. I also have a really exciting announcement that finally we're able to plan our annual in-person conference to mark International Overdose Awareness Day on the 31st of August, which will be held in Glasgow. So please do save the date, and more details about that event and how to book will be available soon. And finally, just a massive thank you to everyone for attending, and a special thanks to today's presenters and panel contributors. Have a really good day, and I hope to actually be able to see you in person in August. Thank you very much, everyone.